going to go into is amyloidosis, right? Now, amyloidosis is an aberrancy with folding of proteins, right? Usually you transcript, you transcribe, eventually translate. And once you translate, you have to, manually, with using your cellular mechanisms, fold those proteins, right? Alpha configuration, beta, and then higher and higher, right? Now, usually if that doesn't work, it could be because of external or other reasons. Then you have amyloid accumulation, right? Usually amyloids are accumulating outside the cells, right? And what are the typical proteins that are, making up these amyloids? It's usually fibril, right? Or substance P proteins, right? And we'll see how those markers can be detected early on with amyloids, right? So primary amyloidosis. So the classification goes as primary versus secondary. Primary amyloidosis, the main and the only example is multiple myeloma, right? The entire, progression of the disease is just based on protein accumulation, right? It accumulates and it accumulates as light chain, which is, light chains are a part of light chain of the antibodies, right? So IgG antibodies, the light chain from those are accumulating, right? Now, that's why you see the L in light chain is the L that is in the AL, okay? So whenever you accumulate a certain type of protein, that's the name that's given to them, okay? So as these light chains accumulate, they can make casts in the kidneys and they can show up in, as proteinuria, right? More specifically, Bence-Jones proteinuria. They're usually negative on dipstick, so you have to use electrophoresis, right? Urine electrophoresis or serum electrophoresis to map out exactly where that M spike is, right? So that's how you know, right? So that, we'll go into multiple myeloma later, but that is a primary amyloidosis, okay? Next comes secondary amyloidosis or reactive amyloidosis. You have a primary disease, and then because of that, you have secondary phenomena of misfolding proteins and cellular mechanisms being disrupted, and extracellular accumulation. Okay, so chronic inflammation wherever it is in the body, for example, SLE, RA, scleroderma, this, that, everything, right? Any sort of inflammation of organs, right? All of those are indicated and they accumulate this type of amyloid, AA, right? Double A. Usually, if you have high amounts of inflammation, liver produces the serum amyloid associated protein, right? That's why it's AA, right? Amyloid associated protein. Okay. Now, most of the inflammation in the body is, it can spread throughout, but the only exception to this whole chronic inflammation rule is chronic bronchitis, because usually chronic bronchitis is pretty much self-contained towards, the bronchioles themselves. Okay. So they're, it's usually not spreading throughout the entire body as most of the other things do. Okay. Cancers mainly, RCC, renal cell carcinoma, or Hodgkin's lymphoma. Both of these are very, very prone to making cytokines, right? And if they do, you end up accumulating AA type of amyloids. They have mentioned a couple more less known, diagnosis, but I still want you to look over them. Familial Mediterranean fever, right? Pyringene. You may not have heard of it, but it's the same thing. And the accumulation is, now it's a genetic based causation. Next thing comes medullary carcinoid, right? Carcinoma of the thyroid, right? Now you accumulate calcitonin in this. That's why it's called ACAL, right? And that's why, you get the whole, if you look at the biopsy of the thyroid, you get the whole amorphous pink material within the thyroid gland, okay? Then comes the accumulation of thyroidine, right? If you are, having this wild type of mutation, and we'll take a look at how transthyretin works, and it's usually, protein seen in old people, right? It's just an age-related protein accumulation, okay? So if that is the age-related accumulation, then it's usually ATTR, and it's usually higher in quantity, and as age progresses. But you can have this type of mutation where you get random high amounts of accumulation, and then you get polyneuropathy because of it. Okay. Next comes Alzheimer's. So Alzheimer's, the main protein that you're accumulating is beta plaques. So that's why it's called A beta. Okay. With hemodialysis in the kidneys, you accumulate beta 2 microglobulin, right? That's why it's called A beta 2. Okay. With diabetes, within the pancreas, you may see some islet-associated pancreatic polypeptide. These are just, like, again, polypeptide chains that are accumulating because, you may have diabetes type 1, type 2, and you're kind of exhausting your, islet cells, and now they're being, replaced by these weird proteins, right? Multiple myeloma we've seen before. So this is a page out of first aid. I do want you to go over it. The only thing that we haven't sort of touched is the transthyretin part, and I just want you to look at it. Now, if you have the wild type of TTR, right, you have the slowly progressive and the aging thing, right? So that's what we're seeing in this branch, right? Transthyretin, TTR. You see, usually this is the sporadic one, and this is the mutant one, okay? And you can see here as well, usually associated with family amyloid polyneuropathy and cardiomyopathy, right? And just for our understanding, transthyretin, right? Trans is transport, thi is thyroid, and retin is retinoic acid, right? Transthyretin. Much like how transferrin works, this is a protein made to carry, thyroid hormones and retinoic acid, vitamin A derivatives. Okay. Now, next comes wherever these proteins accumulate, the cells and the organs will undergo dysfunction. Okay. Kidney is the most common place, and usually the mesangium is the place where all these deposition happen, and eventually they undergo expansion, and so it's called mesangial expansion, and eventually it leads to nephrotic type of syndrome, right? Your expectation is that the person is usually, older. Usually it doesn't present in someone who's young, right? So an older person coming to you with nephrotic syndrome with no other risk factor, you may think about amyloidosis, right? In heart, most common seen in geriatric patients, where is the accumulation taking place? Right beneath the endocardium, subendocardium, right? What do you see? Restrictive cardiomyopathy, right? So the compliance of the heart is toasted, right? You're not going to see any sort of proper filling. You're going to have higher pressures. You will hear S4, and any other sequelae that's related to restrictive cardiomyopathy. Okay. Liver enzymes. Now, liver enzymes, you'll see that usually they're normal, but you may see organomegaly, right? So you may see hepatosplenomegaly being a problem, right? And speaking of spleen, you see spleen has two components, red pulp, white pulp. Red deals with RBCs, white deals with WBCs, and both of them, they've earned specific terms for the type of expansion that they experience, right? In amyloidosis, okay? Skin. Now, skin, again, the accumulation within these capillaries makes them fragile. They can burst, they can rupture and lead to ecchymosis and purpura, right? And this type of purpura is nothing, it has nothing to do with platelets, okay? And because of that, and because of how fragile they are, you can pinch the person, you can give them ecchymosis and purpura right on the spot, right? Or they can present it to you with, the elbows being, purpuric, or the bags under their eyes are purpuric, right? So and that's called raccoon eyes. But you will see these bouts of purpura on like dependent surfaces. Okay. So that is about the skin. Now GIT, most of every organ in the GI system undergoes organomegaly because a lot of them can store. One of the main findings is macroglossia. Your tongue is becoming thick and waxy, and you may see, trouble sleeping, obstructive sleep apnea, some sort of pathology that can that can, bring you to macroglossia and then lead you to amyloidosis. They can try that. Okay. Now, joints. Joints involvement is usually via hemodialysis. And because it's hemodialysis, we know that it's beta 2 microglobulin. And because it leads to accumulation mostly seen in carpal tunnel, you may see median nerve involvement and then the syndrome itself, right? So paresthesia, numbness, different, presentation, right? Blood vessels, usually again, subendothelial, right? Subendothelium. It's not the endothelium. Below the endothelium, that's where the accumulation is. And then you may see that the vessels are fragile, okay? Now, one other important point, early amyloidosis leads to bilateral enlargement of the kidneys, okay? Bilateral enlargement of the kidneys. We're eventually going to see a lot more of these diagnoses that lead to bilateral enlargement. But eventually, in most of those, you will see that the kidney loses its function, and eventually it starts to shrink, right? Because if it's amyloid, or we'll see how diabetes works, we'll see how HIV associated nephropathy works. Most of them will mean that eventually the nephrons exhaust themselves, and eventually the kidney shrinks in size. Okay, so that's another main point. Now, as you go here, you see we haven't talked about the histology, but as you see here, all of these are different, groups of tissues that are experiencing this amorphous material just sitting there. Okay, so this was supposed to be a structured muscle tissue, but now you see the pink amorphous material, right, just present throughout the muscle, right, eventually degrading and causing a lot of problems. Okay. Now, the way you stain it is via this Congo red stain, right? There are several more stains that we'll see down below, but the main one is Congo red, okay? Now, the reason why this gives this apple green birefringence is because amyloid is usually a defect in a beta pleated sheet configuration, which means, if you take a piece of paper and fold it, right, you have two planes of paper now, right? Two planes where the light interacts with the protein itself, right? That's why it gives you the birefringence. So sometimes you may see it's very green in color. Sometimes you may see it's yellow in color, right? So that's why they give that um, green apple green birefringence name. Okay. Now, as you look at different slides, you see they have to give you some sort of accumulation or some sort of antigen, right, to go along with what you're seeing here, right? They have to tell you that this is not a nephron, this is some sort of myocardium, right? And why, what type of, they might even give you what type of amyloid it is, right? And maybe they work backwards. Let's say that this was the heart, and then, yeah, as it says, the myocardium, then they give you the sequelae of restrictive cardiomyopathy, and then you have to decide which um, type of amyloidosis is it, right? So, I mean, in this case, because it's AL amyloid, you may see multiple myeloma being mentioned, some other disease being mentioned, but you have to remember that these accumulations are just sitting there. Okay. Even in this, even if you look in the electron microscopy, you're going to see pools of these amyloids just swirling about. Okay. As you see in this, you may see paleness across the cortex, and you're not supposed to see this. And this means like the nephrons in those areas are basically struggling to stay alive, right? And I see these tubules are being affected. The glomerulus itself has these pink amorphous material inside them, right? So this is, again, amyloid, right? Again, pools of pinkish material, layered, okay, layered within the glomerulus, completely covering the glomerulus, right? And all of this, it can be AL or AA type, some amyloid associated type, and that's about it. Okay. Gross findings. Okay. Gross findings, they may say waxy kidneys. And gross findings, usually it's like an autopsy question. Maybe it's the renal transplantation has occurred and the pathologist is describing what is seeing. So if they ever give it to you, just remember, it's still not inside the person, right? You can't describe it as the gross findings inside the person, right? So the gross stain that they use is called Lugol's iodine, and this iodine makes it stain in a mahogany brown color. Okay, and what they saw is if they put some acid on it, then it turns into a blue color, right? So it shows like a similar finding to starches, right? So it doesn't mean that it's storing starch, no, but it just shows that the color is changing. The iodine is changing the colors of these because of these extracellular materials. Okay. Another place where you see the mahogany brown discoloration is oncocytoma, right? Oncocytoma, renal oncocytoma. We'll take a look at it. It's a part of the benign neoplasms of the renal system, so we'll take a look at it later. But for now, these are the only two conditions where you see amyloids being affected and a renal tumor showing the mahogany brown color. Okay. As you go down, here are the couple of other stains that they can sort of ask you. Methyl violet, crystal violet, PAS stain, right? They can bring them to you. just to confuse you, because a lot of people know Congo red, and they just associate. So that's why they might bring you these types of stains in order to confuse you a bit. Okay. You see the electron fibrils of the amyloid, and a couple of important information, right? Usually, as I said, you have to do autopsy in order to get the gross specimen, right? But what they typically do to stage a person is either they collect abdominal fat or they take a rectal biopsy, right? You see which one is more preferred, right? People would love to take their fat out in order to test for some sort of amyloidosis, right? So amyloid fat aspiration is much more, you see, invasive, right, than rectal biopsy. Then, in order to measure the extent of amyloidosis, right, stage it enough, you may see measuring of system substance P, right? And if it's just a quantitative test. If you have a lot of it, you may see this being elevated, okay? Another sort of finding between hematology and amyloidosis is that amyloid fibers adsorb, right? So these fibers, they, adsorb, which means on the surface, they bind to factor 10, leading to circulatory factor 10 deficiency, which means you cannot make your clotting proteins, your clots, and eventually the bleeding starts to occur, right? So amyloidosis and bleeding, right? And it also, this whole sequelae also adds to the fact that you're seeing purpura, right? So the fragility as well as the bleeding tendency all come together, and you can have these, skin manifestation or maybe even internal manifestations. Okay, so that's about it. And again, the closing it with the first aid part in the nephrotic syndrome. So we don't have to discuss it over there too much, but I hope this helps. Usually the patients that are presenting are older, right? Older in nature. And if they're presenting with nephrotic syndrome, you should rule out everything else before you go into amyloidosis, because there's a lot more common secondary issues of nephrotic syndrome that you may see in an older adult, right? And unrelated to amyloidosis. So make sure you rule out everything else before you get into amyloidosis. All right.